Good morning. My name is Noor, Ahmad. Thank you for having me here. Thanks for the STEAM panel that we got going over here. So I'm going to be speaking about penumbra, in particular lightning flash, which recently came out in the last, I think, 6 to 9 months or so, and what my experience has been. So I'll give a little overview and then some cases, essentially. This is my disclosures. I do speak for penumbra. All right, so we have a first overview and then cases. So penumbra historically, and it's interesting, I think I graduated residency in 2013, so I've kind of seen this evolution in real time happen in my practice in particular. Penumbra originally was a neuro company. The first catheter they ever made was for stroke, right, to essentially aspirate stroke, clot from the brain. So in the design, it's supposed to be a traumatic small bore catheter. Over time, the whole concept with thrombectomy, obviously, as we know, and mechanical thrombectomy is you're aspirating blood. And the name of the game is to basically control how much blood loss that you're having. So over time, with penumbra catheters, they initially started small, and the catheters became larger and larger, and obviously blood loss was a problem. So in 2020, to fix that, what they came up with was this computer-aided mechanical aspiration, and it's an intelligent aspiration system to mitigate blood loss, right? Even not just penumbra, I think all companies. Right now, every company is coming out with a thrombectomy catheter, and really the problem that everyone's trying to fix is this blood loss. So penumbra's system is really an intelligent aspiration, which I'll talk about, I'll get in some detail about. So they built this computer-aided aspiration system within Lightning 12 and Lightning 7. I get always confused between the numbers, honestly. I like to keep things simple, so I say 12.7 flash, basically. 12 was the previous generation, which I still use. I think a lot of us probably still use. It's a 12 French catheter system. Lightning 7 is really in particular for PAD space, for aspiration of arterial clot. Excuse me. That's the lightning bolt system. So flash, what they did was, so the way it works, and I'll get into a little detail in the next slide, is essentially there's these clot detection algorithms that are built in within this microprocessor that you see right here within the system. And the initial computer-aided system was actually was a pressure-based algorithm. Essentially what that means, and I'll talk about it, is they're measuring pressure differences at the end of the catheter and within the system. If there's a large gradient, that's telling you that you're in clot, and that computer is basically telling the system to slow down. What they did with Flash is they added a new algorithm, which is a flow-based algorithm, and I'll talk again about that. So they made it somewhat smarter. What they did was they increased the size of the catheter. Before it was a 12 French system, and there were limitations with a 12 French system. Say you're in the IVC or in the pulmonary artery or in the iliacs, and you're not getting as much space or covering as much surface area. So they made it larger. So this is what I was talking about, this computer-aided intelligent aspiration, that dual clot detection algorithm, which is pressure and flow-based. So these pressure sensors are basically detecting if there's clot or not at the tip of the catheter. If it detects that there's clot, it opens the valve, and then there's constant intermittent suction. If they sense that the pressure is low, right, that means that it's an open vessel, so that valve will automatically close, and then they'll stop suction on its own. Flow algorithm essentially is what that's doing. It's looking within the tubing, and it's constantly analyzing how fast things are going through the tubing. So if it's slow flow, then the flash system picks up. If it's not, if there's blood that's going through it, then it essentially shuts down. This is how it works in real time, basically. This solid green sampling mode that's telling you that you're in patent vessel. Of note, the flash catheter, even though it's larger, there's a worry that you're going to be aspirating more blood. But with the dual clot detection algorithm, it's actually aspirating less blood. So flash is aspirating about thirds of cc's of blood per click that you're hearing. If you compare that to Cat 12 was aspirating about 1.25 cc's per blood, so it dropped it significantly. When you're in clot, it's in this clot detection mode, which is this slot. I don't know if we can hear sound. I guess we're not hearing audio here a little bit, but it's basically this it's a little bit of an intermittent click that you're hearing, and that's telling you that it's in full open suction. And then when it's in, oh, thanks for the sound, appreciate that. Perfect timing. So this is the flash mode when it's activated. You hear that rapid click. That's telling you, so when we were using Cat 12 and we would have to take out the catheter and there's clot within the system, you have to kind of remove that clot, flush it out, and then put it back in the patient. Now with this flash mode, if there's clot detected within the tubing, it kicks into this flash mode, and there's even more rapid suction that's occurring. Thanks. So the flash catheter in itself, they've actually made some significant modifications to the catheter. As I said, they made it larger. The way I like to think about this, and I try to keep things as simple as possible, and I still haven't gotten the Terumo slender radial sheath that, it's a 5 French hole, but you can actually put 6 French catheters because they've basically burrowed out the inner portion of the sheath. It's essentially the same concept with this catheter. It's a 16 French outer diameter, but the inner, they've actually hollowed it out to make an equivalent to an 18 French inner diameter, essentially. So that's the advantage of that catheter now. They've added, or they have 2 different shapes, X torque and H torque. My favorite is H torque. It basically has a 5 centimeter sweep, and that's allowing you to essentially cover more surface area within the vessel. So for example, when you're in the IVC, it allows you to cover the entire surface area, and I have a case showing that later. This is my favorite upgrade to this, is essentially they had this TUI before that, again, Cat 12, you would have to take out the catheter, flush it out on the table, foot saline, send it back in. You couldn't really you couldn't do runs through the catheter. Now with this valve, you can actually flush it or aspirate flush within the system and actually do runs through the catheter. So it's a nice addition to that. This is what comes in the packaging. As I said, there's 80, 100, 115 centimeter working lengths of the catheter. And then you also come with these catheters, which are the Headhunter and the Berenstein tips, essentially. More importantly, for when you're doing PE work and you're trying to track the flash catheter up into the pulmonary arteries, you're actually using the base catheter to help get the catheter up to where you need to be. Of note, it's probably my only gripe of the catheter is there's not an inner dilator or sheath, for the catheter. So we kind of use the base catheters as almost an inner dilator, but of course there's a gap in between. So what are the advantages of lightning flash? In my head, the way I think about it is that it's obviously a soft atraumatic catheter historically, if that's all penumbra catheters. There's no need for a separator. Separator was commonly used for Cat 12. I wasn't a huge fan of the separator. I feel like it, and this is my, I'm not going to get into the, theory of like damage to valves and things like that today, but I think all these catheters, when we think about any catheter that's out there right now, there's potential damage to the valves when you're doing mechanical thrombectomy. So you want to have kind of as much of a soft system. In my head, a separator kind of added shear force inside the when you're doing treatment. So in this case, with lightning flash, you don't need a separator, which is nice. And there's significantly less passes. I'll show a couple of cases which show how quick clot is aspirated with the flash catheter compared to previous generations. So in my head, again, you're passing the catheter significantly less, so you're essentially causing it results in less shear force, and ultimately less vessel wall damage. So again, less trauma equals less damage with hopes for greater patency. Again, there's no real good study yet showing any of this, but again, this is all just theory and based on experience. So I'm going to show 2 cases. This is my first case. This is actually the first time I used flash. This is a 70-year-old male with history of prostate cancer, bilateral extremity swelling, right and left. On CT, had extensive clot, had a filter placed, which actually a patient had clot within the filter. So the way I approached this case, again, this is my first case with flash. I didn't have flash on the shelf, or I didn't know I had flash on the shelf on this point. So usually my kind of algorithm that I think about it for acute clot, if I know if it's acute clot with a wire test or if I just know based on the history, I'm using Cat 12 because Cat 12 is really good for aspirating acute clot. When it comes to, I don't like to say chronic with Kush Desai on the panel here, but when it's subacute clot or old clot, you want to say, that's when I kind of switched over to ClotTriever, FloatTriever, other devices, because honestly, Cat 12 wasn't a great catheter in those situations. So in this case, so that's how I think about it when I kind of prepare. I tell my fellows, what do we got to prepare for this case and what are we thinking about? So in this case, I initially aspirated acute clot with Cat 12, and I was all ready to kind of, there's actually residual clot within the IVC and in the filter, so I was actually all ready to take out the ClotTriever or FloatTriever. In this situation, get access from the other side. Of course, my representative says, hey, I got flash in the car. Do you want to try it out? In this case. So I got access. I was like, yeah, bring it out. So we got access on the contralateral side. This is the initial run showing the residual clot. You could see it's along the IVC and within the filter. And this, if you kind of focus your video or your eyes on the video in the middle, this is me aspirating clot within the filter. And that's just one pass. And you could see the run post. Cleared out all that clot that we initially saw in the filter. Then I focused on the clot that was along the side of the filter. I'm going to go to the next slide here. This was the initial run. Again, this is clot along the side. Again, we're trying to get side clot, so you need an H-torque catheter to kind of get that surface area, that sweep from that catheter. And you'll see in the video in the middle. So I was able to kind of aspirate along the side wall of the IVC and actually popped into the contralateral iliac, which was nice. And again, these are just 2 passes and full aspiration of all clot, basically. And this was more kind of white rubbery clot. We actually suspected this was tumor, so sent it for cytology. Actually came back negative. A little disappointing, but. And of course, I'm at a Sinai conference, so I have to give some ode to inverting a filter as part of retrieval. And this was the post, essentially. There we go. So again, in summary, total blood loss. Cat 12 was the 200 cc's of blood loss, and using a larger bore catheter and just 2 passes in a larger space, I had 50 cc's of blood loss, which was nice. And again, IVC and subacute clot removal removed in just 2 passes. Before, and again, other companies, you have to kind of put the catheter in, take it out, put it in, take it out. It was nice and just removed it all in once. So this was at 3-month follow-up. The patient did well, resolved, no evidence of DVT. This is a second case, 31-year-old female, 1 week postpartum, extensive left lower extremity swelling. You could see the extensive clot burden extending into the IVC. It extended all the way down to the fempop. This was venogram. In the middle, I actually already aspirated clot from the fempop. This is just the iliac system, right? The left iliac, which shows residual clot. Again, this is just in 1 pass, though. I cleared out all the clot within the iliac. And there was an initial pass, which I didn't show, which cleared out all the clot within the fempop system. So in just 2 passes, we essentially cleared out, and she ended up having a May Thurner, which we stented. So again, in just 2 passes, this was a single session outpatient visit. And again, I was just talking about this last night at another meeting. Technology has really evolved in our time, and I think since the TRACT was out there with, with TPA, pharmacomechanical thrombolysis, and now what we're doing, times have changed in just a short period of time, which is just less than 10 years, 5 to 10 years. Now we're doing these type of cases, single session outpatient with minimal blood loss. And this case in particular, which was the biggest highlight for me, was that it literally was about 45 minutes to an hour of room time, right? Fluoro time was 11 minutes. And we're getting these patients in and out, not having to admit them to the ICU. And I think that's the real advantage. You're going to hear about, the ClotTriever and all these other devices today. I think that's the real advantage of the devices today, is that it's really changed kind of the landscape of how we're managing these patients, not just in the hospital. So I know we're in a DVT talk, but I just wanted to give some highlight. This was a patient with a thrombosed tips. This is just to highlight the torqueability of this catheter. This is the only situation, I think Dr. Harnain alluded to this, is that a lot of these catheters you have to use, I didn't mention this earlier, but you don't use it over a wire. When you're in the iliac system, you're actually kind of aspirating without a wire, you're just kind of pushing a catheter forward, which is not really intuitive, right? We don't usually do anything without being over a wire. But this is just one situation I do it, use flash over a wire, which is within a tip stent, essentially. So you see that there's nice torqueability within the stent. Again, just 1 pass was able to clear out all this clot, and it was nice. This is actually relatively older clot, so. And that's all I have. I'm going to stop there. Any questions or?